Welcome everyone to the eMedica MRCGP AKT High Yield Revision webinar for the April 2026 exam. So in terms of the format, what we're going to go through is exam style questions covering key topics, followed by rapid reviews. And you see examples of questions from all three domains, so clinical, stats, admin. We're going to split it into three parts. So part one, we'll go through one question at a time. I'll show you a question. I'll give you 56 seconds to look at it. Then I'll launch a poll. Use the poll to select which one you think is the right answer or answers if it's a multiple best answer. We'll then go through the answer explanations and review the relevant topic or guideline. Part two, we'll do a timed mini mock where you'll do 10 questions one after the other on the optimum pace for those with standard timing, just to get used to answering questions without a break, that if a question is challenging, you've still got to reset your mind and be ready for the next question, and that they're going to be thrown at you from different topics. And then we'll go through the answer and explanations for that. Then part three, we'll talk about how to make the most of the time between now and the exam. We've got just under 8 weeks between now and the April exam. So, how to make the most of that time. And then there'll be a chance for a dedicated question and answer session at the end. Okay, so let's make a start. We're going to go straight into the first question. You've got 56 seconds and then I'll launch a poll. Here we go. Okay, so the main split is between option A and option C. These are the two most popular answers, but it's actually a huge spread of answers. They've all been picked by multiple people. So just highlight this is an area that people might find challenging. Okay, so the correct answer is A, that the hearing in the right ear is mostly in the normal range. Now, as I mentioned, the two popular answers were A and C. The most popular was actually C. So let's look at why so many people might have picked C and why it's wrong. So the reason a lot of people might have picked this, which relates to a conductive hearing loss, is that they might have thought that both of these show the same ear and thought that one is showing air and one is showing bone and there's a gap, and that fits with what you'd expect to see in a conductive hearing loss. Now, one of the things that you'll notice here is that the colors aren't labeled, and that's because that's part of what's being tested here. Okay, so in a standard color audiogram, the right ear is always in red. Easy to remember, refer red, refer right. And the left ear is always in blue. Okay, so what we're seeing here is actually the air conduction in two different ears. Whereas in a conductive loss, what you'd expect to see is air conduction and bone conduction in the same ear, the air conduction being reduced and the bone conduction being normal, forming a gap. That's what you'd expect to see. But the bone conduction is always shown by brackets, and you can see there are no brackets here. So bone conduction isn't shown here. That's actually in itself a clue. When you see an audiogram where they're looking at sensory neural hearing loss, they often won't show you the bone conduction because we're not concerned with it. Okay, so both of these are showing air conduction in the two different ears, the right ear in red and the left ear in blue. And if I draw you a line here, anything above this is within the normal range of hearing. And if you look at the correct answer, that the hearing in the right ear is mostly in the normal range, that's what you see. Look, all the way up to here, even here, this is right on the line of normal. Only at very high frequencies, where we've gone sort of 7 kilohertz, it just dips into this section, which is sort of mild hearing loss. Once you get below this, that's where you get into moderate, and then severe hearing loss is further down. Okay, so whereas, can you see in the left ear, even in the lower frequencies, there's some mild loss, and then it gets to a more moderate degree of hearing loss. Okay, so that's why A is the right answer. That in the right ear, which is shown in red, You see, it's mostly in the normal range. So let's look at standard denotion for audiograms. Now, we know from the examiner's reports that ENT is a topic that people frequently struggle with. And there's a good reason for that. Most people don't get an ENT rotation as part of their GP training. It's one of the less common rotations to get in your hospital jobs, especially now that a lot of people are only getting, one or two hospital jobs because they're spending most of the time in GP. So bone conduction is always shown with brackets, either square or triangular brackets. So here's an example. This is an example of a conductive hearing loss. In this case, both ears, so this is a bilateral conductive hearing loss. So you see in the right ear, the bone conduction is shown by these red brackets. In the left ear, these blue brackets. You see, so they're either like this, square brackets or triangular brackets, doesn't matter. Air conduction is shown with either a circle or a cross. But again, the colors are the same, right? So look, the right ear here is in red, the left ear is in blue. And you can see that bone conduction is normal, air conduction is reduced. That's what you see in a conductive hearing loss. Here's another example of a sensory neural hearing loss. What type of sensory neural hearing loss is shown here? This is typical of presbycusis, the hearing loss of old age, which is usually bilateral. So you see, again, we're not shown bone conduction at all here because we're not interested in it. There are no brackets. We've just shown air conduction in the right ear in red and the left ear in blue. And you can see in both of them, look, normal at low frequencies. Then there's mild hearing loss in the mid frequency. Usually what happens in presbycusis, you lose hearing significantly in the higher frequencies. And you can see once we've got to this, everything above sort of 4 kilohertz, they've got severe hearing loss. So this is presbycusis. Okay. Let's move on to question number 2. Okay, now this is a challenging question for 2 reasons. First, can you see that it's quite a long question? You have a range of question lengths in the AKT. Some will be as short as 3 lines. Some will be 4 or 5 lines. This is a really long question. Look, 2, 4, 6, 8, 8.5 lines of text in the actual question. There's a lot to cover there. And so, that brings in itself some challenge. But the second thing that brings challenge is this is what we call a 2-step question. You can see the actual question is asking about the most suitable management option. To work out what is the most suitable management option, you've got to look through all this information and work out what's the likely diagnosis. So the first step is actually working out the diagnosis. That could be a question in itself. So let's get the learning of that as well. Type into the chat. Imagine the question was, what's the single most likely diagnosis? Type what you think the likely diagnosis is. Because if you get that right, you're going to get the management right, as long as you're up to date with the management. If you get that wrong, there's a much bigger chance that you get the management wrong because you're worrying about the wrong thing. So most people have put as the likely diagnosis epididymo-orchitis or epididymitis, and that's the right lines to be thinking of. Okay. Now, there are a couple of different variants of that. Like the underlying cause of that could be related to an organism related to an STI, or it could be related to an organism related to, say, a UTI. What do you think is more likely for this particular patient? What type of organism? It's more likely to be something like E. coli related to a UTI, right? Because they recently had a UTI and they've not recently been sexually active. Okay? Look, in the last month, they've not been sexually active. Whereas if they had recently been sexually active, then, you might lean more towards an STI variant. Again, that would change the management. You see, it brings a lot of challenge. So The correct answer is D. Treat with levofloxacin 10 days. Now, what's the relevance of Prensine? So Prensine is really useful to separate epididymal orchitis from torsion. So if someone had torsion, first of all, for this patient and the age, it's less likely. You can get it at any age, but it's something that we usually see in a younger age group, right? But in torsion, so Prensine is where you elevate the scrotum, thereby elevating the testes. And in epididymal orchitis, Prensine is positive. So when you elevate the scrotum, the pain gets better. In torsion, the pain won't get any better. In fact, just touching them, the pain gets much worse, right? So it can be useful if you're not sure. So we should already be leaning more towards that anyway because of the patient's age. But this is another important thing to help separate that. Whereas, can you see, if you thought it was torsion, if you had a younger patient and Prens was negative, then, you thought it was torsion, that needs to be admitted for surgical management, doesn't it? But this is why this is the right answer. So how does epididymal orchitis present? It has a gradual onset. It's painful, it's tender on palpation, there's a swelling, it's usually on one side, there's erythema overlying it, and Prensine is usually positive. So when you elevate the scrotum, thereby elevating the testes, they say that the pain is slightly eased, it gets better. Okay. How would we manage it? Because that's what the question was about. Well, if the patient seems septic, really severe symptoms, they've got high temperature, they seem really unwell, well, those patients will need admission because they might need IVs. Otherwise, so most patients, they're not that unwell. We can either manage in GP or refer if they're happy to be seen and you can get an appointment that quickly in a gum clinic in GU medicine within 24 hours. If you can't get an appointment that quickly, which is not possible in a lot of places nowadays, we can treat it in GP. And you treat based on the likely cause. So if you think that it's likely to be an STI variant, things like gonorrhea are common causative agents. Chlamydia can also be involved. So you think about things like ceftriaxone, doxycycline, azithromycin. If you think an enteric organism, like those related to a UTI, E. coli, for example, is quite common, is more likely, i.e. they're low risk for STI, then either ofloxacin for 2 weeks or levofloxacin for 10 days. Now, I'll show you something else that's really important in terms of exam technique, because to do well in the AKT, you need both good knowledge and then you need good exam technique. Part of that is reading the scenario and the answer options carefully. So do you see the two options that are correct for this patient are either ofloxacin or levofloxacin? They're both long-term. So ofloxacin is 200 twice daily for 2 weeks. Levofloxacin is 500 once daily for 10 days. Now, if I go back to the answer options, you can see if you had a younger patient, Prens negative, you thought it was torsion, then you'd be thinking about surgical management. If you thought it was an STI, so this patient had been sexually active and it fitted better with that, then you might be thinking about along these lines to cover for gonorrhea and chlamydia. Why is C wrong? Because ofloxacin is one of the treatments. Because look, the option says ofloxacin single dose. The correct answer, if you're going to give ofloxacin, you need to give it twice daily for 14 days. One dose isn't going to do anything. Do you see? So that's why C is incorrect. And actually quite a few people did pick C. And then the correct answer we had was D. Okay, let's move on to the next one. Okay, great. So the split here is between A and B. So advised no need for antibiotics. That was actually the most popular answer. About half of you picked A. Then just over a third picked B. And then the rest were split between C and D. Okay. So again, this is a two-step question. to work out the suitable management according to the fever pain criteria, you can see the first step is to calculate the fever pain score. So let's do that. What if the question said, what is this patient's fever pain score? Okay, so we've got answers ranging from 1 to 4, okay, and everything in between. So 1, 2, 3, 4, all of these have been picked. You can see if you thought it was 1, then you'd probably say no need for antibiotics. If you thought it was 4, then you'd say start antibiotics today. And as there's no mention of any allergies, then you'd think about Pen V because that's the first line. Okay, so you can see where people have got those. The correct answer in terms of the fever pain is 3. This patient's fever pain is 3. Why? Because the fact that they've attended within 3 days or less, so they've attended within 2 days, that's 1 point. The fact that they had a temperature, whether now, you can see it's afebrile now, or within the last 24 hours, and that includes, measured at home. Earlier in the day, it was high. They get a point for that. And the fact that the tonsils are inflamed, they get a point for that. So that's 3. And that's why the right answer is to offer a delayed script. Okay. And as I mentioned, as there's no allergies mentioned, first line is Pen V. Whereas if they had an allergy, then you could use clarithromycin or erythromycin. So let's just go through fever pain first of all. You get 1 point for each of these. So the fever is fever within the last 24 hours. Now that includes measured at home. I think that's one of the things that throws some people. Some people saw that they're afebrile now and therefore discounted this, or thought that it doesn't count unless it's measured in clinic. Self-reported fever, one measured at home is still count as a point. Okay. Then we've got P is for purulent, so pus on the tonsils or the back of the throat. They didn't have pus, they just had inflammation, so they don't get a point for the pus. A is attending rapidly, so within 3 days or less from onset of symptoms. They came in 2 days, so they get a point for that. I is inflamed tonsils, they get a point for that. And N is no cough or coryza. Now this bit's important. Again, some people misunderstand this bit. And so some people would have looked here and said, okay, there's no mention of a cough. And so they might think that they get another point. It's no cough or coryza. If they have a runny nose, that's coryzal symptoms. They don't get a point for this. They have to have neither of these. If they have either cough or coryza, they don't get a point. The N covers both. They're not separate. Because if they were separate, can you see? Then someone could score 6 because someone could have no cough, get a point, no runny nose, bunged up coryzal symptoms, get another point. You don't. These two are combined. If they have either one of these, a cough or coryzal symptoms, they do not get a point. And they had coryza, so no point. Do you see? So that's why their score is 3. And then in terms of the interpretation and management, if they score 0 or 1, the evidence is that there's a very little chance that it's bacterial. And so we don't give antibiotics. 2 to 3, there's a moderate prediction or probability that the cause is bacterial. And so we could consider a delayed script. 4 or 5, there's a high probability that it's bacterial. Then you think about starting antibiotics today. And in terms of which antibiotics, if they have no allergies, first line's Pen V for 10 days. If they're allergic to penicillin, then clarithromycin or erythromycin, those are for 5 days. Okay, good. Let's go to the admin domain. Okay, great. So the most important thing here is that the patient that's put in the request, they don't want to access their own records. They want to access their father's records who's passed away. can see that the next of kin and the executor of the will. And, they might be thinking about negligence. So the correct answer here is E. If you want to access someone else's records who's passed away and you have a legitimate interest in those notes, you're the next of kin, you're the executor of the will, you think there's negligence. That's the common reason why people want it, is that they're thinking of legal action. Then you request it under the Access to Health Records Act. Well done, about half of you got that right. Of those that didn't, a lot of people picked C, the Data Protection Act. That's used if you want to access your own information. That's the most common one that's used, but that's when people want to access their own. You can see the patient's not trying to access their own records, it's someone else's. And then the other popular answer was this one. We'll talk about that one now. So 3 important bits of legislation in relation to health records. The Data Protection Act 2018 is what you use if you want to access your own information. If you want to access, let's say a company for occupational health reasons wants to access information on their employees, then they could apply under the Access to Medical Reports Act 1988. And then if you want to access someone else's records who's passed away and you've got a legitimate connection and reason to do so, then you apply under the Access to Health Records Act 1990. Okay, let's look at part of the evidence-based practice domain, which is data interpretation. Here we go. Great, well done. So most people have got this right. So the correct answer is Bradford, B, and that was the most popular answer. The second most popular answer was A, Barnsley, followed by D, Doncaster. So let's look at why people might have picked either Barnsley or Doncaster and got this wrong. So first thing is to read carefully what's being asked. The question is asking for the area that had the worst cardiovascular mortality for women under 75. If you look at the data that we've got, you can see we've got data for all causes, so death for any reason, all cause mortality, sometimes that's just called mortality, in under 75, split by persons, which means male plus female, male and female. And then you've got a subset of this data, deaths where the cause of death recorded was some form of cardiovascular disease. That could be a stroke, it could be a heart attack, it could be anything related to cardiovascular illness. Okay, so the first thing is to make sure you're looking at the right line, which is this one. You see cardiovascular mortality in women, which is what the question asked for, and then you're just looking for the highest number. These are deaths per 1,000 people. So 65.6 is Bradford. So why might have people picked Barnsley, or why might have they picked Doncaster? Common reason for that is if they missed this bit, this one word, and they just looked at mortality in women under 75 rather than the subset, which the question was asking for cardiovascular. Because if you look at mortality rate for all causes, Barnsley had 318 per 1,000. Doncaster had 324. Both of these are higher than Bradford. So those of you that picked A or D, this is why you were probably looking at the wrong line. And the reason for that is missing this. So again, do you see? Part of exam technique, reading the question carefully. Every word matters. Right, so and increasingly this type of data interpretation question where they ask you to interpret real life public health or practice level data is more common. You still do get some of the classical questions looking at graphs and charts that you might see in a study, but these type of questions are a lot more common now in the stats domain. Okay. For example, this is looking at specific age bands, demographic data from a specific practice. It's actually the NHS practice where I've worked as a locum on and off for 15 plus years. This is looking at broad spectrum antibiotic prescribing for a practice in London. This is called a quinary graph. So this is looking at age bands in 5-year categories and looking at male and female. This is for a practice in Manchester. And then this is look at infant mortality in different areas. This is called a leaf plot. Looks at pre and post test probability. And this is a Kate's plot or smiley face graph. So this is an example of a way to demonstrate visually risk to a patient. Okay, all of these have been featured in past exams. You know, these type of graphs and charts. You need to know how to interpret them. Right, and then if you found that way of learning helpful, where you do a question at a time, then we go through answers, explanations, and you understand not just why the right answer is right, but the common incorrect answers, why people might have picked them. So you start developing not just the knowledge, but you improve your exam technique. That is the method of learning in our AKT Masterclass webinars, which are coming up. So they're available live. They're also available as recorded self-paced courses that you can do. And if you join the live session, you also get access to the recording for a month afterwards included. So we have Statistics Made Simple, covers 60 plus key stats topics by going through 50 questions. That's because sometimes after I do one question and go through the answer and explanation, I'll talk about the theory of several other topics that are related. So that's a half day. The same day in the afternoon, we have the organizational domain organize, cover the key admin topics. Again, 50 questions, 60 plus key admin topics. And then high yield clinical grammar 1 and 2. These run over 2 long evenings, 7 p.m. to 10:30 p.m. each evening on a Wednesday and a Thursday evening. 50 questions, 60 plus topics each evening. So across the 2 evenings, we cover 100 clinical questions, 120 plus topics. They're all topics though that were mentioned in examiners' reports. These are things that are frequently retested. So you can book them separately. £125 for stats or admin, they're half days. £250 for both of these together, because together they're the same amount of hours as a full day course. Or if you book all 4, it's significantly discounted. So stats, 50 questions, 60 plus topics. We've had lots of people that found stats scary or didn't like it, really master the key topics and then go on to get great scores. So 100% in stats here, 100% in stats, 95% in stats, 90% in stats. Some of these were people that before that, they really were scared of it, or like, look at this person, they felt they were weak in stats. That's why they were proactive and did it. Went from feeling it was a weakness to not just passing, but smashing it, 90%. And then admin, again, 50 questions, 60 plus key topics. Lots of people, again, done really well in admin, 95% in admin, 95% in admin, 90% in the organizational, 95% in the organizational. And then high yield clinical 1 and 2. So 100 questions, 120 odd topics across the 2 days. Okay. But all of these are topics mentioned by examiners. Okay. Again, lots of people that mastered those topics. So those are coming up. I'll show you where you can find them later on. My colleagues have posted the link. But we're going to move on to the second part now, the mini mock. All right. I say mini in that we're going to do 10 questions. All right. So we'll do 10 questions, 56 seconds per screen. Now, some of you might be wondering, if the exam's 160 questions in 160 minutes, that's 1 minute per question. Why are we doing it at 56 seconds? If you spend a minute per question, you will just about finish the last question as the buzzer goes. You allow no leeway for the odd question that needs a bit longer. You allow no leeway if there were some questions that you had to completely guess, that you flagged and you wanted to go back to look at later. At a pace of 56 seconds per question, you will build up around 10 minutes, which will allow you a bit of leeway that if there is the odd topic that you need a bit longer, or you flagged some questions and you want to go back to them, that 10 minutes will give you that time. That's why we're getting you used to that optimum pacing for standard timing. Okay, so what will happen this time, there'll be no polls. All 10 questions will go one after the other. The screens will move forward automatically after 56 seconds. So you've got to commit to an answer. And then I'll go through answers and explanations for all 10 in one go at the end. Okay, and this is the way that we do it in our half mock grammar and our full mock grammar courses. I'll talk to you about those later. So the first question is going to start now. Okay, good. So we're going to go through the answers and explanations. I won't use polls this time so that we can save time. We're going to go through each one, mark your own. You get 1 mark for each correct answer. So question number 6. Key things here is looking at what is this patient's current total opioid usage. So they're on 120 milligrams BD of modified release morphine, i.e. they're currently using 240 milligrams of oral morphine. So if we're going to change that because they now can't swallow because of the progression of their disease, to giving them diamorphine via a syringe driver, CSCI is continuous subcutaneous infusion, because that's how we deliver it via syringe driver, right? It's a subcut needle and it just gives a very small drip continuously over a 24-hour period. So it's about understanding opioid equivalence. So diamorphine is 3 times as strong as oral morphine. So 240 milligrams is the total oral morphine. Divide that by 3. You're going to put 80 milligrams of diamorphine into the syringe driver over 24 hours. Okay. So let's just go through the calculation. If they're on 120 milligrams twice daily, so the first common mistake here is some people miss the BD and they know the conversion. So they see 120 and they think, okay, I'm going to divide that by 3, and they end up with 40. And that's why they get it wrong. The other common mistake is people don't know the conversion. So they see 120, they see the BD, so they multiply it to 240, but then they divide by 2, which would be the case if you're putting morphine, which you can put in a syringe driver. The reason we more commonly use diamorphine is that when you're giving something subcutaneously, you've also got to think about the volume of liquid. And diamorphine is more concentrated. So are you getting a greater amount of analgesic cover in a smaller concentration of liquid? Okay, that's why it's more commonly used than morphine. But you can use morphine. If you were to use morphine, then you need to divide by 2. Okay. So we've got 120 of oral morphine twice daily, that's 240. Divide that by 3, that's 80. And this is the table in the BNF that covers this, of how you convert oral morphine to syringe driver, either morphine or diamorphine, i.e. injectable. Okay, so morphine is twice as strong when it's given as an injection compared to oral morphine. Diamorphine is 3 times as strong. So you divide by 3. And remember that you want to first look at, when you're calculating their 24-hour oral morphine requirement, you should also include if they're having some breakthrough doses, how many of those they're using. You add that into the total. Okay, this is a set of 2 extended matching questions. Can you see it says genetics 1 of 2, but the question is question 7. In this case today we're doing 15 altogether. Okay, and quite subtle, because I saw in the comments some people, when it moved to genetics 2 of 2, the question's very similar. Remember, the answer options remain the same in a set of EMQs, i.e. A, B, C, D, E, F, G. These options will stay the same. And the difference between this question and the next one was very subtle. So in this one, what we've got is 2 people who are carriers for hemochromatosis, and they want to know the risk that, if they have a child, what's the risk that their child will have hemochromatosis? They're just carriers. They're worried about their children having full-blown disease. So the correct answer is C. The risk is 25% that they have the disease. And that's because, what's the method of inheritance of hemochromatosis? What's the way it's inherited? It's autosomal recessive. So you have to get 2 of the faulty genes to get full-blown disease. If you've got 1, you're a carrier. So they're both carriers. So that's the risk. Now, you see the second one, genetics 2 of 2, the scenario is largely the same. The answer option is the same. What's different is the actual question. In this one, they want to know the risk of their children becoming carriers, not having the disease. I.e., what's the risk their children will be like them, carriers of hemochromatosis. And remember, often carriers, sometimes we say they have trait, they sometimes still have some symptoms, but they're often milder, right? The risk is 50%. So D is the right answer. Okay. So if we go through autosomal recessive, and this will be the same for other autosomal recessive diseases, like cystic fibrosis, for example. Okay. So look, mum is a carrier. She's got 1 hemochromatosis gene and 1 normal gene or healthy gene. Dad is also a carrier. They've got 1 hemochromatosis gene and 1 normal or healthy gene. Now, you get one from your mum, one from your dad, right? So look, if you're unlucky, you get the hemochromatosis gene from mum and the hemochromatosis gene from dad, you're HH. Now you have full-blown disease. Do you see there's only a 1 in 4 chance that that happens, 25%. There's a 50 chance that you get one hemochromatosis gene either from mum or dad and a normal gene from the other parent, and you end up HN, just like them, 50% chance. And then there's a 25% chance that you're fortunate, you get the healthy or normal gene from mum and the normal gene from dad, you're NN, you are not only are you not a carrier, you can't now give it to the next generation. Okay, so if both parents are carriers for an autosomal recessive condition, there's a 50% chance that any of the children will become carriers, 25% chance that they will have full-blown disease, and a 25% chance that they're healthy non-carriers. Okay. And it's also worth knowing the modes of inheritance of, some of the relatively common and important disorders for the UK population. And I've listed those here for you. Okay, question number 9. So this is challenging because it's what we call a multiple best answer. So in a multiple best answer in the AKT, you can see it will give you a number of options that you have to pick. And so it says which two. You have to get them, in this case, both right. If you get one right and one wrong, you won't get half marks. There are no half marks in the AKT. You either get it fully right, you get a mark. You get it totally wrong or partially correct, you get nothing. Okay? So the question's also challenging because it's a negatively framed question. It's asking which two of the following would not be recommended as part of the diagnostic workup. The majority of questions in the AKT are positively framed. They'll ask you what you should do or what is the diagnosis. But you might get the odd question, sometimes only a handful in the whole exam. Sometimes there might only be 1 or 2 out of 160 questions that are negatively framed. Sometimes there might be none in some papers, okay? But you see, so if you missed this, you might have the knowledge and still get the answer wrong. So the first thing is to think about, with the description of symptoms, erratic periods over a year, periods, variable, then no periods, then restarted spontaneously, also got some mood symptoms, various other things going on, not on medication, otherwise healthy. What do you think that we're thinking about? And the age is really important here. I.e., what is it that we're trying to diagnose when it says what would not be recommended as part of the diagnostic workup? What we'll be thinking about is premature ovarian insufficiency or premature menopause. Okay? So what would not be recommended? The correct answers are A and H. The guideline specifically recommends that you don't do a pelvic examination if you're trying to diagnose this, that there's no need to do that, and that you shouldn't use AMH testing, anti-Mullerian hormone. So you'd need to get both of these right to get the mark. If you got one right and one wrong, or you got it fully wrong, you get nothing. Okay. So when should you be suspecting premature ovarian insufficiency or premature menopause? The age is really important. So under 40, they're not on the combined pill, and they've got menopausal symptoms. So that could be infrequent periods or periods stop then spontaneously start. Raised FSH, so 30 international units per litre or more on 2 different samples, at least 4 weeks apart. And then other things that are part of the workup that is recommended: LH, estradiol, prolactin, thyroid stimulating hormone, testosterone. What's not recommended is to do a pelvic examination routinely and using AMH testing. These are not recommended. Okay. Right, admin domain, GMC guidance. So again, it's a multiple best answer. Now, one of the things here is that it's easy, if you're in a rush, to confuse GMC with GMS. GMS stands for General Medical Services. It's one of the 4 types of NHS GP contract, and that has guidance on gifts, which is different to what this question is asking about. It's asking about the GMC guidance on gifts. Okay, and sometimes people will confuse the two, and even though they've got the knowledge, they might then lose a mark. And again, it's a multiple best answer, so you're going to get both right. So which 2 of these statements are correct? The correct answers are B and F. So in terms of what the GMC says, I'll also cover what the GMS contract says, but in terms of GMC guidance, that while it's generally not recommended to accept gifts, and you're certainly not allowed to encourage gifts You can't pressure patients to make donations to even good causes like charities or anything where you might directly or indirectly benefit. That if they give it voluntarily and it's not going to be deemed a conflict in interest, it's not going to be deemed inappropriate in that, they haven't got dementia, for example, or something like that, then in some situations you can accept a gift. And that they don't set a specific value. What they say is that if it's an unsolicited gift, if it's of minimal value, it can be accepted. But they don't specify a set amount in relation to that. So the reason that sometimes people get this wrong, sometimes people will pick E. Gifts with a value of £100 or more need to be reported. That's true of the GMS contract guideline. So for example, if you're working in a practice that holds a GMS contract, that's the most common NHS GP contract, then you're bound by the GMS contract regulations. And that has a regulation that if you accept a gift with a value of £100 or more, that you need to record that in a register of gifts. Okay, that you keep at the practice, that's available for inspection by the primary care organisation, if they request it. But that's got nothing to do with the GMC guidance. The GMC guidance doesn't specify one value. Instead, it does mention in like the notes section that different NHS organisations might set different values. So for example, some hospitals it's £50, some hospitals £25. It does actually mention that in some GP practices it's £100, but it doesn't specify one set value that can be accepted. It just says minimal value, and it says that this can vary in different places, and it gives some examples. That's not a set amount. Do you see? So the correct answers are B and F. Okay. So let's look at what the GMC guidance says first, and then we'll look at the GMS contract. So you're not allowed to encourage patients to give gifts or to give donations, even if it's to a good cause, if it's something where you might directly or indirectly benefit. You can't alter the management that you offer or the services that you offer based on gifts, because then it's a bribe. You shouldn't accept a gift if it might be seen as inappropriate or a conflict of interest. So, as I mentioned, if you've got a patient with dementia, don't accept a gift from them because they might think they have to give you some payment for service because they haven't got the capacity, you see. Whereas if none of those apply, and someone gives an unsolicited gift, then if the value is minimal, it can be accepted. And those of you that are being in GP, if you were in GP over the Christmas period, you'll see it's actually really common for patients that have been with a particular name GP for a long time. Around Christmas time, it's quite common that they will drop off gifts. What the GMC also does say, though, is that if you do accept a gift, doesn't matter what it is or what the value is, you should document in the notes that you got a gift. What the GMS contract, which has got nothing to do with the GMC, it's one of the 4 NHS GP contracts, and we'll cover, those of you joining the admin webinar, we'll cover all of the 4 NHS GP contracts. We'll cover the GMS contract in detail, because that's the one that they tend to ask more questions about. But one of the clauses within that is that they specify £100 as a high value gift. And they say that if you accept a gift worth £100 or more, you should record that in a register of gifts that you keep at the practice. Question number 11, rheumatological disease. So important things here is that the small joints of hands and feet are affected. So, we've given some painkillers, probably some NSAIDs, given their symptoms, order some blood tests. What's the most appropriate next step? Correct answer is A. They should be referred to a rheumatologist within 3 working days. You don't wait for the test results. Anyone where you suspect rheumatoid should be referred within 3 weeks. So it's already quite quick. But those that should be referred even more urgently, i.e. within 3 working days, there's 3 categories. If the small joints of the hands or feet are affected, and that's this patient, actually it's both for them, small joints of hands and feet, either one would be enough to warrant a 3-day rather than a 3-week referral. If more than one joint is affected, or if by the time they come to see you, they've already had symptoms for at least 3 months, because they're likely to already have significant disease progression. So the quicker they get referred and they get onto disease-modifying anti-rheumatic drugs, the quicker that we can try to sort of stop the progression or slow it down. That's why it's not recommended to delay the referral while you wait for blood tests. Or even if the blood tests are normal, if they've got symptoms, you refer. Assessing alcohol intake. So the key thing in this question is reading the scenario carefully. And one of the things that people sometimes miss is how many glasses that they're actually drinking. How many glasses of wine does this patient drink in a week? Great, 9, right? Because sometimes people just see the numbers. It says 7 nights a week, they have 1 large glass, so they think 7. Because it says on Saturday and Sunday, because, look, they're a teacher, they're not working on the weekend, they have another glass with lunch each day. So on Saturday they have a large glass, on Sunday, i.e. 9 in total. So there's 2 ways that you can then calculate how many units. One is, if you just learn how many units are in common drinks, and then you know that a large glass of wine at about this kind of strength has got 3 units in it, roughly, then you can just do 9 times 3, which is 27. Okay? And you'll be close enough. The other is to use the formula. So I'll go through both so that you know how to do it accurately. If you've got one where you need to be absolutely precise. This is just a shortcut. That in a large glass of medium strength, which is about 12% alcohol, if you had one that was much weaker, is a bit less, you might use the formula. If it was much stronger, you might use the formula. But about 12%, 250 mils, large glass, about 3 units. And they have 9 glasses, so 9 times 3. The other way is to use this formula. The number of units is the volume in milliliters multiplied by the alcohol as a percentage by volume. Take that total and divide by 1,000. So look, in one glass, 250 milliliters multiplied by 12, because it's 12% alcohol by volume. So multiplied by 12. I'll show you on the calculator. Okay. So make that a bit smaller for you so you can see. So we've got 250 mils and it's 12% alcohol by volume. So we're going to multiply by 12. That gives us 3,000. And you divide that total by 1,000. So if we divide that by 1,000, that gives us 3. And then you just need to multiply that by how many glasses, which you already calculated as 9. 9 times 3 is 27 units. Now, one other thing that's important is that how do patients give you drinking histories? Most patients I've met, and I'm a portfolio GP, one of the roles I work in is I work in detox. I cover 2 different community detox units, one in Birmingham, one in Kenilworth. Is that almost no patient I've met in my career knows how many units or what a unit is. Because they go to the pub and they order a pint, or they have a large glass or a medium glass, or they order a shot. And so sometimes the history might be given how a patient would give it to you, and you then might need to use that formula to calculate. So you might need to be able to work out some of the numbers. For example, if a patient says to you that they have a pint each evening, they might not tell you how many milliliters that is, because the patient doesn't know. You need to know how many milliliters is in 1 pint, which is a common amount that people will order if they're having a beer or a lager. How many milliliters is it? The correct answer is 568 milliliters is in 1 pint, because pints are in imperial units. They don't fit neatly into the metric system. Okay, so it's 568 milliliters in a pint. It's worth knowing that, because that's a common unit. So let's look at how many units are in common drinks. So wine at about 12%, a medium strength. Small glass, which is 125 mils, is 1.5 units roughly. A large glass, which is 250 mils, is about 3 units. Beer, standard strength beer, is about 3.5 to 4% alcohol by volume. So a unit of that's a half pint. A pint is about 2 units. Remember, a pint is 568 milliliters. Premium beers or lagers, these tend to be a bit stronger, 5 to 6% alcohol by volume. A pint of those are about 3 units roughly. Spirits, 25 milliliters of any spirit at 40%, which is the most common strength of spirit sold in the UK, is 1 unit. Sometimes this is described as a single shot or a single pub measure. And then cider is often at a similar strength to premium beers and lagers. So a pint is about 3 units. And if you want to be accurate, then this is the formula. Units is the volume in milliliters multiplied by the alcohol by volume. Okay. Take that total and divide it by 1,000. That's how many units is in that drink. Okay, question number 13. So, because this guideline's very recently changed, I'll launch a poll for this one. I'm interested to see what people put. Great, so the most popular answer is F. Start insulin, detamir, continue metformin and dapagliflozin. That's the most popular answer. Followed by C. Start NPH insulin and continue metformin and dapagliflozin. Okay, that's really interesting. So the correct answer, and what's important of note here, is that there has no other significant medical history. So you can see he's already on 1, 2, 3, 4, so quadruple therapy, and still poorly controlled. What's the level of HbA1c when someone is on multiple medications, where we generally say the control is poor enough that we should think about the next step in the guideline? What's the important cutoff? What's the number? 58. Yeah, excellent. Okay, you can see they're well above that. They're 70. Okay, so that's why we want to go to the next step. So the correct answer is B. Less than a fifth of people got this one right. Now, it's a hard question, plus the guidelines just changed, which is why I want to cover this. All right. So the reason that NPH insulin is a good choice for this patient rather than detamir or glargine. Detamir is an example of a long-acting insulin. Okay, and the reason that we're going to put him on this and keep him on his metformin is that this level is here at 70. If this level was 75, we might go straight to a combination of an intermediate insulin and short-acting insulin around meal times. And then when might you think about a long-acting insulin like detamir or glargine? Generally, patients who they're having lots of symptomatic hypos, there's no mention of that here, or if they need help with injections. And again, there's nothing to suggest that they're otherwise well, they don't have any other significant medical history, nothing to suggest that they need carers or someone to come in. Often then it's easier because it's longer acting if they need help with the injections. So let's look at the guideline and let's look at how we initiate insulin in primary care. So when we got someone who's already gone through the guideline and still is poorly controlled, the next step then is insulin, right? And an intermediate insulin is generally the first line. So you can start that as a once daily or twice daily regime. Generally, I will start them once daily, give it in the evening because they've got their metformin to continue as well during the day. And then if that's not enough, you might then go on to adding in short-acting insulin or a twice daily regime if necessary. And the guideline recommends that for patients that you're type 2 diabetes, they're already on multiple medications, not well controlled, you're moving to insulin, that you continue their metformin and you review the others. Okay. So if they were on other medications just to manage hyperglycemia, then apart from metformin, you'd stop all the rest, like this patient. It doesn't mention any other illnesses. Whereas, if you've got patients who they might be on other agents because of increased cardiovascular risk, because of obesity, because of other things, in which case those you might continue. So for example, in the new guideline, you've got some patients who, because of other risk factors, they might be on Ozempic as well. And if they've got that additional risk factor ongoing, you might keep them on that. You might have patients who were started on other things because of another specific risk factor. You might keep them on that because of that additional risk. Okay, but if they were on other things to try to control their sugars, as in this case, it's not mentioned that it's got heart failure. It's not mentioned that they're obese. It doesn't mention that they've also got hypertension or chronic kidney disease or obesity. There are no other medications. Doesn't mention any. It says there's no other significant medical history. In that situation, just continue the metformin. You can stop the others. And then you might have some patients. So for example, if you had a patient where maybe they were in this category. They're having lots of hypos, and you think, okay, either detamir or glargine. And one of the other changes in the new guideline is that if you've got more than one type of insulin that would be appropriate, i.e. if either detamir or glargine would be suitable for a particular patient, then you should use, if they're equally good, pick the one that's more cost effective. For this particular patient, he's not a good fit for this, he's a better fit for this. Okay, so NPH, neutral protamine hagedorn. Anyone know where that's derived? Because we have synthetics, we have things that are derived from porcine products, bovine products, human insulins. Anyone know the NPH insulin, where that protein comes from? It's from a fish protein. It's derived. Okay. And so one of the things when you put someone on a basal insulin regime is that you also need to continue to monitor their blood sugars, because if they're still not well controlled, so they're still on metformin and you've added an intermediate insulin, then you might need to add a short-acting insulin around mealtime to keep those sugars under control. Okay, now this is an example of a free text question. So in the exam, just there's no A, B, C, D, E, there's no options to guess from. You would type your answer using the keyboard at PSN View to type your answer into the box. Okay, so the correct answer is 41,560. Now, do you see two things that are important here? It says, what's the incidence per million? And the reason for that is the World Health Organization asked all countries to record COVID incidents during the pandemic per million. So we could compare data. You can see, because if you had one country reporting per 100,000, another one reporting as a percentage, another one reporting per million, makes it difficult. So they asked everyone to report per million for standardization. That's why we've used this. This is actual data taken from, a specific year during the pandemic, 2020. And then this other bit's important, to the nearest whole number. Because one of the things there is, if you calculated it, the exact amount is actually 41,560.39. If you put 0.39, even if that's precise, you would not get the mark because you haven't followed the instructions, which was to round it to the nearest whole number. That's because either a person has COVID or they don't. They can't just have it in their arm. Do you see what I mean? You can't have 0.39 of a person that has COVID. A whole person has it or a whole person doesn't. That's why we round it to the nearest whole number. Okay, so let's go through the calculation. Incidence is the number of cases, okay, the number of new cases as a proportion of the population. So the first step is to take the number of cases, 2,770,000, and divide it by the population given, 66,650,000. That gives you this number. Those of you then that multiplied by 100, you can multiply something by 100 by moving this dot two places. You would have got 4.1 and you rounded that to 4. What you've done is calculated it as a percentage. That's 4%, okay? Because percent means per 100. When you calculate it as a proportion of the population, in the last step, you always multiply by however many you want it per. If you want it per 100, that's what percent means. It means per 100. You multiply by 100. If you want it by per million, then you have to multiply it by a million in this last step. So if we take this number and multiply it by a million, we get this, 41,560.39. Now, how to round to the nearest whole number? You look at just the first number after the dot. If this number is 4 or lower, then the nearest whole number is this number. You just stop at the dot. You don't have the dot, you remove these bits. This is the nearest whole number. If the first digit after the dot is 5 or higher, you add 1 to this number. So for example, if this was 41,560.51, then the nearest whole number will be 41,561. So if the number after the dot is 4 or lower, this is the nearest whole number. If it's 5 or higher, you add 1 to the last digit here. Okay, so in this case, it's 41,560. Any other number here, so if you put this 0.39, you wouldn't get the mark. If you put 4.1% or 4% or 4, you wouldn't get the mark. This is the only correct answer. Okay? No human looks at this, it's marked by the computer. So incidence, the rate of new cases of a disease. You look at how many cases there were, divided by the population, and then if you want it as a percentage, because sometimes you will, there are some things that we will describe as a percentage, then you multiply by 100. If you want it per 1,000, you multiply by 1,000. If you want it, in this case, per million, you multiply by 1,000,000. And generally, you look at it over a year. Okay? And then the last one, looking at drug safety. It's another important topic. So what's correct in relation to NSAID use in pregnancy? The correct answer here is D, that the MHRA advises additional monitoring might be required if they used it from week 20. Now, this is an important change because historically, there have always been known risks around NSAIDs for decades, but historically, what do we used to say? It's contraindicated once you're past 28 weeks. But because of this recent MHRA alert, the evidence is strong now that there are significant risks earlier than previously thought. So, what we used to say before, that in the last trimester specifically, we used to say 28 weeks onwards, it's contraindicated. And that's because the risks are, it can cause premature closure of the ductus, it can cause renal dysfunction in the fetus, it can prolong maternal bleeding time, so increasing risks of postpartum hemorrhage. It could inhibit contractions, making a prolonged labor, which increase risks of infection and so on. And it's a class effect. So, really any NSAIDs, ibuprofen, naproxen, diclofenac, anything in that class. But that new data highlights increased risk with prolonged use from 20 weeks. And so, they looked at all of these risks. Reduced fluid because of renal dysfunction in the baby, constriction, which can lead to heart dysfunction. And so they now recommend that, one, we don't prescribe NSAIDs in the second half, basically, 20 weeks onwards, that we advise patients not to get it over the counter, and that if they had it, even for just several days, at any point after 20 weeks, then we need to consider additional antenatal monitoring to make sure that they haven't got oligohydramnios. Okay. So add up your total score. You get a number out of 15. Remember, we did the 5 questions one at a time before the mini mock. Then we did the 10 questions in the mini mock. Add up your total. If you got 11 or more, that gets you into a pass for any sitting of the exam historically. That would be enough to get you into pass. If you've got a 10, that's borderline. In some sittings, it would just about be a pass. In most sittings, it would just about be a fail. If you've got 9 or less, don't worry, you're not there yet, but you're not sitting the exam tomorrow. All right? And also, we've only done 15 questions. Your exam has 160 questions, and this is a high yield revision session. We're deliberately going to focus on topics where either guidelines have recently changed, or we know, like the diabetes one, or we know that it's areas that people struggle on from past examiners' reports, like things like ENT, audiograms, So let's look at how to make the most of the last 8 weeks of your preparation. By this stage, hopefully you've already done a good chunk of revision, covered significant amount of the curriculum. What you want to do is continue to systematically cover any gaps and any weaker areas in your curriculum. You definitely want to make sure you cover stats, admin, and the higher clinical topics. And that's because stats and admin, while they're 10% each, there's only so many things that they can ask in those topics. If you cover them well, then you can get 80% plus in stats and admin. That will allow you to get away with sort of 75% in clinical and you'll pass. Whereas if you can't get a really good score in stats and admin, then you need 80% plus in clinical to pass, and that's more challenging. Ultimately, clinical is most of your questions, it's 80% of the questions in the exam, and so clinical is going to be most of your time. But you definitely want to make sure you've got a good handle on those things. As we get to the last 30 days before the exam, if you complete our 30-day challenge, so on our YouTube channel, there's a video to watch each day for that last 30 days. Some stats, some admin, some clinical. So way where 5-10 minutes each day, you cover lots of topics that can help you with your preparation. And if you're not already on one of our programs, so those of you on our Pass Guarantee program or on our AKT Pass Plus program, you know, those things I mentioned earlier, the stats, the admin, the higher clinical 1 and 2, and then we've got, you know, how we learned here, where we did 10 questions in one go. That's how we learn in a half mock grammar and a full mock grammar, where half mock grammar, you do 40 questions in one go. Then we go through answers, explanations, topic review, you know, and you get a handout. Then you have a break, then we do another 40. In half a day, we cover 80 questions. In the full mock grammar, we do 4 40-question mini mocks. So we cover 160 questions in one day, okay? And that's in this way, where you do them all in one go, and then we'll go through the answers and explanations without the polls. Well, that's a good way to cover a lot of gaps, to consolidate key topics, and to improve your exam technique, because that's really important. And the other way that you're going to work on your exam technique is to, you know, use a question bank to do questions, to make sure the things that you've read, can you actually apply it when it's given in a question format? And I recommend the last month before the exam, doing one timed mock exam each weekend leading up to the exam. So you get used to managing your time, you get used to seeing, you know, broad spectrum questions across the clinical curriculum, stats questions, admin questions, and so on. How to cover the high yield topics. We publish a high yield topic checklist. So, you know, after each examiner's report comes out, after the exam results come out. So we recently had the January exam results. The report will be out probably next week, week after. And they'll highlight some of the topics that people didn't do well in, or important topics that they're happy they did do well in. Those are high yield topics. They frequently retest those. Well, I've tracked those from every examiner's report ever. And there's some topics that come up again and again and again, and they go into a high yield topics checklist, and I update it after each new examiner's report comes up. So, you know, downloading this, putting it somewhere you can see, ticking off and making sure you covered these things, because if any of these came up and you hadn't read them, you're going to kick yourself, because examiners are telling you these are things we think are important. They're frequently tested. So all of the things we've done today, they're all, you know, part of this checklist. Now, if you want to read a specific guideline, you know, go to the source, the original source, NICE. Their site has guidelines by topic. But if you want to cover lots of them efficiently, then you can get hold of our clinical case cards. We update these at least once a year, so they, you know, stay up to date. It's 112 topic reviews, so it's 56 double-sided cards, and they're mapped to the same things that your questions are mapped to. They're available within the UK as a printed version. They're available worldwide digital edition, and there's a bundle where you get access to the digital one and the printed one delivered to the UK. So I mentioned our half mock grammar. The way that you did a 10-question mini mock, we do a 40-question teaching mock, then go through the answers and explanations. Then we do a break, then another one. So, you know, 80 topics in a half day. And the full mock grammar, 4 40-question teaching mocks. So we cover 160 in one day. So these different things are available in discounted bundles. So I already talked to you about our masterclass bundle. That includes the stats webinar, which is a half day, the admin webinar, a half day, the higher clinical grammar, 2 3.5 hour evenings. Okay. You get a PDF course booklet for each one, so that's 4 booklets in total. That doesn't include our question bank or any full mock exams. You know, you can book those separately, but it does include over 14 hours of learning and over 200 topics. If you book the bundle, it's £349, over £150 discount compared to booking all 4 separately. If you want to add to that the full mock grammar, that's our AKT 500 bundle. That's 500 topics, 5 course booklets, and it includes our full mock B. Okay. And then our AKT 600 bundle includes all of those, and it includes the half mock grammar as well as the full mock B. So, you know, 600 plus topics for £600. So it's a bigger saving compared to booking all of those separately. But all of those are available, and these are the dates for the April exam for the different live sessions. Now, any of these that you book, if you're not available, you will get access to the recording afterwards. And if you're not available for any of them, you can just directly subscribe to the recording. So I'll show you how to find them. So if you go to our website, emedica.co.uk, everything AKT is here, from our pass guarantee program to a structured program over either 90 days or 150 days, which includes everything we offer, plus daily and weekly tasks and an individual targeted revision plan, to our Pass Plus bundle, which includes everything I showed you there, plus our full day AKT course, which we already ran a few weeks ago, and our half day how to pass the AKT, plus our printed case cards and our question bank, and all the different mocks. Okay, and then the other bundle I talked to you about, so the 600, that includes the half mock crammer, the full mock crammer. So, all of those you can find there. Okay, similarly, if you just wanted the stats webinar, for example, you can find it here. So you could book just the stats webinar, you could book the stats and admin and high yield clinical 1 and 2. You'll find everything in this section for AKT on the eMedical website. Okay, but these are the dates for all the live sessions coming up. So Saturday 21st March, stats in the morning, admin in the afternoon. 25th March in the evening, high yield clinical crammer 1. 26th, the Thursday, high yield clinical crammer 2. The half mocks at the end of March. And then 11th April is the full mock crammer. It's a full day, it's an intensive day. Okay, and please do connect with us. You can find us on all of the popular social media channels. So we're on Instagram, TikTok, Facebook, and our YouTube channel. We put lots of different things there. So the recording of this will be available there. There'll be a link to also download the teaching slides that we've gone through. Okay, the topic review, once the video is up. So if you subscribe, as soon as it goes up, you'll get a notification. Those of you on our Pass Guarantee program, it will be added to your resource page automatically. But for anyone else, if you subscribe to our YouTube channel, you'll be available there by the end of next week. And I leave you with this, that as we get closer to the exam, don't count the days, make the days count. That's what Muhammad Ali said. That, we're getting to the critical part now before your exam. You want to make sure every day you do something. Don't let one day pass you by that you've not at least done some questions or read one topic or revised one guideline or, made some progress. Even if you had a busy day in clinic, there might be one patient that you saw that you think, I'm going to read up the guideline related to what they came to see me about, so I don't let that day escape. And then, on another day when you're not as exhausted, you're going to do a bit more. But just make every single day count that is progressing you closer to your goal, that you're consolidating knowledge, that you're working on exam technique, that you are getting closer to your goal of passing. Because ultimately, prepare and you will succeed.